Welcome to Innovations in Hypertension Management with a specific focus on renal denervation, presented by Albert Einstein College of Medicine of Yeshiva University at CardioCare Live. You are tuned into today's final live session, which is not understanding resistant hypertension, but it covers Simplicity Hypertension 3 and renal denervation in general. My name is Professor Markus Schleich. I'm a renal physician, hypertension specialist, and head of the Neurovascular Hypertension and Kidney Disease Laboratory at the Baker IDI Heart and Diabetes Research Institute in Melbourne, Australia. I'm joined today by a panel of international experts in the field of hypertension management. It's my great pleasure to welcome Professor Deepak Bhatt from the Harvard Medical School in Boston, USA, Professor A.J. Katani of the Columbia University Medical Center in New York, USA, and Professor Luis Ruilope from the University in Madrid. For those just joining us, I would like to remind you that today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I very much encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce Professor Deepak Bhatt. Professor Bhatt is Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital Heart and Vascular Center in Boston, Massachusetts, and presented findings of the Simplicity Hypertension 3 trial at the American College of Cardiology scientific session just last week. Deepak, thank you very much for joining us today, and I'll hand over to you to talk about Simplicity 3 and its results.
Great. Well, thank you for inviting me to speak here. So I'm going to go through much of what I had gone through at the ACC late-breaking clinical trial session, realizing that some of our audience may have seen that and probably a large proportion hadn't. I'm going to move through things at a pretty brisk pace just so that there's adequate time for the panel to really discuss and for us to answer questions that you might email in. Before I get started, let me just share with you my disclosures relevant to this talk. I've received research funding through my hospital from Medtronic. Medtronic was the sponsor of Simplicity Hypertension 3. I'll also mention, in particular for any U.S. audience members, what I'm talking about is off-label and investigational in the United States. So, by way of background, there's already been great discussion that you've heard earlier in this program about resistant hypertension and so forth, but at least to provide a little bit of perspective for why we did this trial, it was a recognition that hypertension is a growing problem worldwide. About 10% or so of patients diagnosed with hypertension have so-called resistant hypertension. Of course, one could argue about the exact number, but it's somewhere in that range. As you heard very eloquently laid out earlier in this symposium, the sympathetic nervous system plays an important role in resistant hypertension. And prior non-blinded studies had suggested that catheter-based renal artery denervation reduces blood pressure in resistant hypertension, often with dramatic effects. That is the background upon which we launched Simplicity Hypertension 3, the first prospective multicenter randomized blinded sham control trial to evaluate both the safety and efficacy of percutaneous renal artery denervation in patients with severe treatment-resistant hypertension. The trial included 535 patients enrolled by 88 participating U.S. centers. And it was a U.S.-only trial. It was designed really to be the pivotal trial for potential FDA approval. And in terms of the sites, let me just show you here a map of all our sites. And I just want to pause for 1 second to just point out these are among the best interventional sites in the U.S. And there have been some questions about the proceduralist, the procedure, and so forth. And we'll, I'm sure, come back to discuss the procedure itself and the catheter itself, and if that was the reason for the overall null findings of the trial. But I certainly don't think it was the operators, because at least within the context of the United States, these were high-volume coronary peripheral interventionalists that were very skilled. So very proud of our sites and our operators. So in terms of various committees, for the sake of time, I won't go through all of this other than to say that, again, we had really the best academic groups involved with all aspects of the trial. In terms of the inclusion criteria, it was pretty straightforward. Patients between the ages of 18 and 80 on a stable medication regimen that included full tolerated doses of 3 or more antihypertensive medications of different classes, including a diuretic, which was optimally dosed, with no changes for a minimum of 2 weeks prior to screening, and no expected changes for at least 6 months. So met the definition of resistant hypertension. The office systolic blood pressure had to be greater than or equal to 160 millimeters based on an average of 3 pressure readings measured at both an initial and then a confirmatory screening visit. And of course, written informed consent needed to be provided. Key exclusion criteria are listed on this slide. And as you can see here, the ambulatory blood pressure monitoring needed to show a 24-hour systolic average of greater than 135 to be included, or in other words, if it was less than 135, patients were excluded. So this was an attempt to weed out patients with white coat hypertension. The other exclusion criteria are as follows: an eGFR of less than 45, and then a bunch of different angiographic exclusion criteria, really things that were meant to signify that maybe it wouldn't be a good idea to do denervation. The diameter had to be at least 4 millimeters. There had to be at least 20 millimeters of treatable length. Couldn't be a significant aneurysm or renal artery stenosis or prior renal artery intervention. So a number of different angiographic criteria. Shown on this slide is the overall design of Simplicity Hypertension 3, and I'm just going to walk everyone through this a little bit. This is important in terms of interpreting the trial results. So there was a screening visit 1 that occurred. The office systolic blood pressure had to be 160 millimeters of mercury or more. Patients had to be on full doses of at least 3 antihypertensive medications of complementary classes, maximal tolerated doses, no medication changes in the prior 2 weeks, and no planned medication changes for the next 6 months. So that's screening visit number 1. 2 weeks elapse. During those 2 weeks, home blood pressures are monitored by the patient, and they keep a home diary confirming, documenting by self-report, whether they were adherent with their medication. Screening visit number 2 occurs. The office systolic blood pressure is confirmed to be greater than or equal to 160. 24-hour ambulatory blood pressure is confirmed to be greater than or equal to 135 millimeters of mercury, and their diary is checked to make sure that they're saying that they're adhering to their medications. And now some might say, oh, well, you know, how good is a diary for confirming adherence? That's a legitimate question, but there were a fair number of patients who were screened out of the trial because they were honest and they said they weren't taking their medicine. So it certainly did screen out overtly non-adherent, honest patients, you know, ones that were. So were there potentially patients who were not being adherent that in their diaries said they were adherent? Of course that's possible, but we were relying on the honor system. So that was the rather rigorous screening process. If the patient made it through those different screening procedures, a renal angiogram was performed. If there were none of the anatomic exclusion criteria I briefly alluded to, then the patient could be randomized to either renal denervation or to a sham procedure. And the sham procedure was basically a renal angiogram with some blinding procedures as well. It wasn't that we actually went up with the catheter in the sham group and just didn't plug it in. That would have been a complete sham control, but we did what we thought was ethical and feasible, which is a renal angiogram, which the patient would have needed anyway to be in this trial as the sham control. The primary endpoint, which was office systolic blood pressure at 6 months, or the difference between baseline and 6 months, and then the difference between the 2 arms, was ascertained at 6 months. 2 weeks prior to that, though, the same sort of screening that occurred at baseline occurred again, where patients kept their home blood pressure, where they documented medications in a home diary, and also had an ambulatory blood pressure monitoring done. So that was the 6-month time point, and then the 2 weeks before that. Patients randomized to the sham procedure at that 6-month point after the primary endpoint was ascertained had the opportunity to cross over unless they no longer met the inclusion criteria or unless they developed an